Good afternoon. I'm Dr. Stephen Lloyd. I'm the medical director of the South Carolina Medical Endoscopy Center and the Carolina Colonoscopy Center, where we are able to protect patients much more effectively against colorectal cancer, which currently is the #2 cancer killer in America. And what we're just talking about is contrasting the ability of colonoscopy when done with the tandem technique compared to another common screening test for cancer called mammograms. Mammograms are able to reduce a woman's risk of dying of breast cancer by about 25%. But mammograms do not prevent cancer. This is an early detection test. And colonoscopy is a prevention test. Colonoscopy is able to keep a patient from getting colon cancer. And the way that is achieved, colon cancer doesn't start first as a cancer. It starts as a little growth we call a polyp. And what very few people in America are aware of is how long it takes those little polyps to degenerate all the way into cancer. The average is over 12 years. If we do a colonoscopy anytime during those 12 years, identify the polyp and effectively and precisely destroy it, the patient eliminates the risk of turning into cancer. So we can prevent about 85% of the cases of colon cancer and more than 90% of the deaths if we can continue to get the patients to come in and have the screening test done and have it done with the precision and the efficacy that we're able to achieve with the tandem colonoscopy, which is heavily dependent on the GI technician to assist the doctor in it being able to visualize all of the surface of the colon, and when we find a polyp, to be able to put it in a configuration that we can precisely destroy the polyp. So the basic premise about why colonoscopy is so effective at saving lives and preventing suffering from colon cancer is because of that notion of the polyp to cancer sequence that takes 12 years. So we've talked about the polyp and how long it takes to turn into cancer. What are some of the risk factors? What are some of the things that we worry about? What patients are at higher risk of getting polyps and therefore getting colon cancer? Well, clearly colon cancer correlates very closely with the patient's age. The older we are, the more likely we will form polyps, and those polyps will slowly march in that progression towards cancer. There are other factors that increase your risk. African American males die twice as frequently of advanced colon cancer than whites. People that are sedentary, people that eat too much red meat and don't eat enough vegetables, people that drink too heavily, and especially the highest correlating risk factor is a family history. If you have a brother or sister that had colon cancer, you have 4 times the risk of having polyps in colon cancer. Well, let's talk about the different screening tests. We know that the test that we're promoting is colonoscopy because it has both the simultaneous opportunity to look at the colon, find the polyps and destroy them, and prevent the cancer all at the same time, whereas some of the other tests are almost cancer detection tests like the mammogram is, like the Cologuard test that gets so much press now. It's 97% effective at finding colon cancer, but it's nearly worthless at finding polyps. And so Cologuard is sort of like the mammogram for the colon, but it's not like colonoscopy. It is not going to protect people from getting colon cancer in the first place, and that is our mission. There are some other tests out there. They're stool-based tests that you can get done in the doctor's office, or now you can purchase them at the pharmacy that do take a little sample of fecal material and analyze it to see if there's some blood in there. And if there's blood in there, that could be coming from either a very large polyp or an early cancer. And again, these are considered cancer early detection tests, not prevention tests. So in summary, the most common tests to screen for colon cancer are the gold standard test, colonoscopy, but also you have the stool tests, the Cologuard, the FIT, and the FOBT, which are tests for hidden blood or shedding DNA from cancers. And these are early detection tests, not prevention tests. Let's take a minute and talk about the anatomy of the colon. The colon is the last 5 feet of the digestive tract. And the purpose of the colon that a lot of people, even doctors, are unaware of, the colon is not where you digest food. It's not where you absorb the carbohydrates or the proteins or the fats. The main purpose of the colon is to convert the waste material that's finished the 25 feet of small intestine and convert that waste material from a liquid, which is how it arrives in the colon, until it turns into solid over that 5 feet trip. It goes up, across, down, and out. During that 5 feet trip, it gets compacted and most of the water is removed so that the stool becomes fairly firm and formed. Some people's colons work a little bit too well and they end up having chronic constipation because they have these hard, dry stools because the colons work too well at removing all the water. The first part, when we're doing the test, we look at the patient from the butthole up, whereas normally from an anatomical standpoint, we think of the colon as starting where the appendix is, where the cecum is, and going up, across, and out. But let's start from the part that we would see during the colonoscopy test. The first thing the doctor's going to do is do a rectal examination to be sure there's no blockage, and external visualization to see if there's hemorrhoids or any kind of abnormalities that we can visualize. And then they do a digital rectal examination with some KY jelly to see if there's anything abnormal that they can feel within the reach of the finger. From then we insert the colonoscope and we go through the rectal area into the sigmoid colon, which is the next section. This rectum is about 20 centimeters or about 5 inches long, 5 to 10 inches long. And the rectum is one of the most common places to have polyps. From the rectum we go into the sigmoid colon, which is usually from about 20 centimeters in to about 35 centimeters. The sigmoid tends to be fairly curvy, and it's one of the difficult areas. It has the first major turn, which is a challenge for the doctor and the GI techs to be able to get it through there without causing undue discomfort or possibly injuring anything. From the sigmoid colon, the next section is called the descending colon. It's a straight section. It starts at about 35 centimeters in and goes to about 65 centimeters. And that's right there on the left side. Then there's a sharp turn at where the spleen is, called the splenic flexure, and then the colon tends to hang right below the diaphragm, right beside the stomach, in the upper part here, called the transverse colon, and that's a long section that goes all the way from 60 centimeters or so to 100. And at that point, we reach the liver, which is called the hepatic flexure. Hepatic means liver in Latin. And from the hepatic flexure, it's a straight shot down into the beginning of the colon where the appendix is and the cecum. And so the total distance in the colon is about 120, 130 centimeters. The scope itself is only 165 centimeters. And so sometimes we end up using all the scope before we've actually achieved the end of the colon. We have to bring the colon scope back and forth a few times till the colon snugly gets onto the colon gets onto the scope, so that we have enough scope to get to the very end. And this is the key of the GI tech in the tandem colonoscopy model, is to assist the doctor in getting all the way to the end, which we achieve in over 99% of cases. The national average of getting to the end of the colon is only about 96%. But in the tandem colonoscopy, because the doctor has so much assistance in being sure we stay in the center of the colon, we don't have undue pressure on the colon walls, we're able to get to the end more than 99% of the time. And it's because the technician is doing the advancing of the scope, and the doctor has both hands to be able to control the precision tip deflection, keep the scope inside the center of the lumen, and allows us to be able to traverse the entire section of the colon. And so, in terms of our anatomy, we talked about the anus and rectum, the sigmoid, the descending colon, the transverse colon, the ascending colon, and then we're at the end where the appendix is in the cecum. And those are the sections that we will examine. And once we get to that area, then it's the slow, as we come out, we do circles to be able to look very carefully at all the surface area. And when we find polyps, that's the fun part. That's when we get to assist the patient by removing the polyps precisely. And that'll be our next section that we'll talk about. We've talked about the anatomy, we've talked about the epidemiology. Now we're going to go on to the therapeutic part of the GI tech's role in helping the doctor keep the patient from getting colon cancer by removing the polyps. So our next section will be polypectomy. This is Stephen Lloyd. Nice to talk to you, and see you soon.